So as the chair requested, a little bit about FIND. So FIND stands for Foundation for Innovative New Diagnostics. So we are a product development partnership. We're headquartered in Geneva, and we have offices across India, Vietnam, and in South Africa. The organization is primarily focused on development of new diagnostics for infectious diseases, as well as delivery and access. So while the R&D part, where we largely work with our partners in the industry, academia, and in the research community, is where we are engaged in the development of new products. The country offices are largely involved in increasing access to these products by working with the country governments as well as with the stakeholders in the private sector. So my talk, as my organization's focus is largely going to, talk about the diagnostic needs to address the emerging challenges associated with the antimicrobial resistance. AMR is already a growing threat, and there are about 700,000 deaths which are already occurring annually, and if unchecked, they may potentially climb to about 10 million by 2050, 10 million per year by 2050. On top of that, there are about 500,000 MDR-TB infections, with India accounting for a large percentage of those infections. And then the total economic burden of AMR is currently at a staggering $10 trillion. With the potential of going up to almost 27 trillion by 2050. What is also particular to note is that AMR today can impact almost anyone, anywhere, with potentially devastating impact on those who are obviously have a compromised state in terms of whether they're immunocompromised or are in the hospitals engaged in long-term care, and also the neonates which are rapidly contracting drug-resistant infections. Coming to the context of India and why there are challenges as far as the AMR is concerned, there was a very recent report in the Proceedings of National Academy of Sciences, 2018, which indicated that antibiotic consumption, which is a primary driver of AMR, increased in India by 103% between 2010 and 2015, which was in fact the highest in the low and middle income countries. There was a rapid increase in the use of last resort antibiotics, and also a significant increase in the use of broad-spectrum antibiotics, particularly the third-generation cephalosporins, which are rapidly replacing the fluoroquinolones, which are becoming resistant, especially for the management of dysentery and bacterial fevers. On top of that, there is a lack of suitable diagnostic infrastructure in the public health sector at the primary and the secondary level. In the private sector, as my predecessor spoke, there is high cost and there is low affordability as far as the patients are concerned. Unfortunately, diagnostics today does not come under the ambit of insurance, and the patients tend to spend almost all of the money out of pocket. From an insurance standpoint also, less than 20% of the population is today covered by any kind of insurance, which basically means that there is catastrophic expense on account of the patient when it comes to accessing healthcare in the private sector. There is also a bunch of social factors. The concept of self-medication, again referring to the slide from my predecessor, she referred to the Lal Lakir or the Red Line campaign, which was launched by the Government of India back in 2016. However, the impact of that, it has not yet been seen, and the propensity to self-medicate continues unabated. Then in 2014, government included the antibiotics in the Schedule H1, or the restricted category of drugs, basically to prevent the non-prescription based sales of the antibiotics. However, that does not seem to have in any way impacted the easy over-the-counter availability of the antibiotics in India, something which is driving antimicrobial resistance. We yesterday spoke about the environmental contamination. Yes, while the pollution control boards, both at the central level and the state level, can play a very important role in the management of environmental contamination through the antibiotic residues, but India's Central Pollution Control Board still doesn't have any standards as far as the effluent emission is concerned. Moreover, even the WHO GMP norms 2015, they mostly talk about good manufacturing practices, but there is not much focus as far as the disposal of effluents is concerned. Now, over the last few years, there has been a whole bunch of policy and AMR containment initiatives launched by the country, which is indeed creditable. However, there is very little evidence so far to indicate whether these policy initiatives have been in any way effective. We do understand that there is a lot of good work which is being done, as was highlighted by Dr. Kamini from the Indian Council of Medical Research, but I still believe this is a drop in the ocean and more efforts need to be brought into place in order to combat the scourge of AMR in India. Now, diagnostics, has a critical role to play across the AMR Global Action Plan, and this is whether you talk about so diagnostics, as I said, they have a critical role to play across all the elements of the Global Action Plan, and this is whether you talk about the optimization of the use of the antibiotics, and these diagnostics, they are required, for example, for the detection of pathogens or the resistance of the antibiotics, depending upon where they're deployed. And then continuing from the previous slide, diagnostics obviously can play a very important role in reducing the overuse of the antibiotics, and by reducing the selective pressure on the pathogens, they can obviously help treat patients faster and more correctly, and overall reduce the hospital costs by reducing the risk of acquiring drug-resistant infections, and also offer better return on the drug discovery investments by preserving the life of these newer drug entities for a longer period of time. Now, the diagnostic needs, they require addressal across the patient value chain, and also take into account the level of healthcare infrastructure where these patients are actually accessing the treatment. Now, when you talk about the community healthcare centers, what is needed is, for example, a triage test which could potentially differentiate between the viral or the bacterial markers. What is also needed are tests for the identification of community-acquired pathogens, be it in a point-of-care test format, or be it, simplified phenotypic or molecular assays. Tests are also required for the identification of resistance and for the susceptibility and for checking the susceptibility of antibiotics, across the healthcare levels from district hospitals up to the national reference centers. Of course, depending upon the healthcare center, the nature of the test available, that needs to be deployed appropriately. Dr. Nusrat spoke about the need for blood cultures. It is in fact easier said than done, because the current technology as far as the blood culture is concerned is highly complex. It is highly training intensive. Hence, there is a need to develop more simplified blood culture solutions if they need to be deployed at lower levels of healthcare. Again, from a surveillance perspective, it is critical to be, conducting surveillance, and this is across the various levels of healthcare, whether you're talking about the pathogens or you're talking about the antibiotics. It is also important to audit the prescription practices so that you can understand what are the antibiotic prescribing trends. The diagnostic algorithms, they need to be looked at continuously, and they need to be modified as and when the newer diagnostics get introduced into the healthcare structure, whether at the public healthcare level or within the private sector. This is a small example of how an existing RDT test can potentially become a driver of the antibiotic use. Now, according to the World Malaria Report 2015, in Southeast Asia, out of the 140 million malaria investigations that were conducted, only about 1 million were positive. This basically means that 99% of the patients who ended up being diagnosed as malaria negative were not given a clear diagnosis. Now, this is a clear recipe for antibiotic misuse. And there was a study which was done in 2016 in Malawi, for example. 60% of the under 5s with the fever who did not need the antibiotics actually ended up getting prescribed antibiotics. Similarly, the malaria, in the same study, it was also reported that for the malaria RDT negatives, the odds of getting an antibiotic were actually 16.8 times higher than those who were malaria RDT positive. Similar study in Tanzania, where again, a large majority of the malaria negative patients actually ended up getting antibiotics where they may not have needed any. Another study in Laos, again pointed towards, indicated that half of the dengue patients, they ended up receiving antibiotics, and all of us know that, there is nothing really that a dengue patient needs apart from regular hydrotherapy. Switching the gears a little bit to talk about, our FINDS AMR strategy. We are largely focused, our strategy is basically three-pronged. and we are largely focused upon optimizing the use of antimicrobials through the introduction of point-of-care tests to enable the selection of optimal therapies for common non-bacterial infections, preserving the newer drugs by associating these newer treatments with appropriate diagnostics so that you can preserve their efficacy for a longer term and the patients don't start getting resistance to these newer therapies. And also empowering surveillance efforts, through connected surveillance tools to track and map the emergence of resistance. Some of the work that we are doing in this space as an organization, we already spoke about malaria, and malaria-negative patients will actually benefit from a simple triage test to guide treatment beyond malaria to inform antibiotic prescribing practices. So what is needed is basically a target product profile for this kind of a test, and this is something which was published late last year. A target product profile for a diagnostic assay to differentiate between bacterial and non-bacterial infections. Then validation of host biomarkers in the low and middle income countries to understand utility in the context of common comorbidities. Also develop sample biorepositories. Find, in fact, already has 2 sample biorepositories. We are also working very closely with the industry on the development of certain point-of-care tests. We're working with BD, a device and diagnostic major, to develop a multiplexed biomarker assay. We worked with a Korea-based company called ST Biosensor to develop a malaria and CRP test, where the addition of CRP to the menu could potentially point towards a bacterial infection. We are right now in the process of undertaking trials with the National Institute of Malaria Research for this particular test. There is also a multiplexed RDT test for about 8 pathogens, which has been developed in collaboration with ChemBio, and later this year we are planning to trial this test at a couple of locations in India. Also, talking a little bit about the AMR Diagnostic Use Accelerator. This was launched in November 2018, and it is supported by catalytic funding from the DFID UK and from the Swiss Agency for Development and Cooperation. The overall aim is to support 2 African and Asian sites. We are also collaborating with the Indian Council of Medical Research in India to launch an RFP for a diagnostic accelerator, where the idea will be to source high-quality proposals, which would be focused on looking at how you can use the existing point-of-care diagnostics to combat the antimicrobial resistance. The last slide from my side, in terms of concluding. So obviously AMR and all the other emerging threats, they require responses at multiple levels. Diagnostic needs, they need to be addressed across the entire patient value chain, both from a point-of-care perspective as well as the laboratory-based diagnostics. Multiplexed RTs are something which are the need of the hour, so that the physicians are rapidly able to diagnose the underlying infections at the bedside level. Diagnostic tools in the high-income countries may not always fit the requirements of the low and middle income countries. And important to look at cross-cutting activities and finding common interfaces with antimicrobial stewardship programs, or working with the pharmaceutical companies in order to bring down the scourge of AMR. And in the end, obviously, no one partner can address the challenge. Strong partnerships are needed to fight the scourge of AMR. Thank you.